Patient is being diuresed with IV diuretics, and you're worried that the urine output is not at goal. You sign the patient out to the CCU float. What do you tell them to do about the diuretics? Metolazone, then bumetanide. Bumetanide, then metolazone. Bumetanide and metolazone at the same time. And the fourth option is, what the heck are these meds? I will give you 15 seconds to think it through, and then we will proceed. So the answer here is metolazone, then bumetanide. And we're going to discuss why. Sorry, I should have given you a trigger warning again for the nephron. I apologize. On the right, you may have seen this diagram. It's a fantastic schema. Please remember that any diuretic will promote reabsorption of sodium and hence water distal to the channel that you're blocking. And that's why if you gave acetazolamide, it's not a very strong diuretic. Everything just gets reabsorbed later. So if you really want to maximize diuresis, you have to give the distal blocker first. So we're going to talk about the cascade of events that you should attempt and a little bit about the diuretic-free interval. So every diuretic has a ceiling effect. And so there's a minimum dose of diuretic to generate urine output. For some patients, that's furosemide 20. For some, that's 40. For some, that's 80. At a certain dose, you're not going to get any more effect. So you give 80 and 120, and you have the same amount of urine output. Please remember, in patients with CKD, they have fewer nephrons. You're going to have to give a higher dose. So those are patients that require maybe 80 or 100 IV of furosemide or any loop diuretic to get an effect. There's something called the diuretic-free interval. So when a diuretic stops having an effect, your body actually tries even harder to resorb water because it thinks it's dehydrated. And so if you dose furosemide, Lasix, every 6 hours, maybe in the last hour, your body's ramping up its RAS even more than usual and will try and reabsorb water. So you can mitigate this in two ways. You can frequently dose, or you can give continuous diuretics to avoid the diuretic-free interval. And the reason I bring this up is this depends on how aggressive you want to diurese your patient. And that depends on how overloaded they are. So you really need to understand the indication and be kind to your patients. So this is a balance. Here are the reasons to avoid diuretic-free intervals, and there's reasons to promote it. And so if the patient is rapidly approaching cardiogenic shock, be aggressive. So you're going to have to pick their comfort second over their safety. So if they have to pee all night, that's what happens. And then if they're actively suffering because of tremendous volume overload, be aggressive with your diuresis. If they're not in cardiogenic shock and they're making steady gain on routine diuretics, don't torture them. Let them have a diuretic-free interval. And I think that's nice because that's probably what they're going to go home on, and they're going to have that diuretic-free interval, so it simulates the outpatient setting. And then if your patient is losing sleep because of diuretics, that's another reason to say it's okay to have a diuretic-free interval. So to summarize, if you want to maximize the diuretic effect, you start distal and you go proximal. So to review the classes that we have in our armamentarium, it's a potassium-sparing diuretic, followed by a thiazide diuretic, followed by a loop diuretic, followed by a carbonic anhydrase inhibitor. So if you give all four, patients will sure as heck urinate. SGLT2 inhibitors technically are on this cascade as well, somewhere between the loop and the carbonic anhydrase inhibitor, so you can use that to potentiate diuresis too. Remember, give the distal diuretic first. Give multiple classes of diuretics as opposed to just escalating a single dose. That tends to work better. You do have to balance that with the patient's ability to tolerate having 4 meds on at once. That can affect their quality of life greatly. And in severely acute settings, it's okay to limit the time between diuretic doses. And finally, avoid late night doses if they are not critically ill. That's all I've got.